it's well, you don't know chalk.
No, I thought it was just gray.
No nail polish names the color gray. It's like espresso yourself. They're not gray. It's
all right. Well, I want to thank you guys for all coming today. And this is we're finally back to live lunch and learns, or snack and learns, I like to say. I want to introduce Dr. Roseanne Barker. She has been in sleep. Well, she's been a doctor for 30 plus years, and she's been and she's has her own sleep center. She's been all over the country giving presentations just like this to other doctors and other people, and she's just wonderful resource, and I'm so glad that she could come today. And she's coming very far from just Walker Springs, we flew her in. We're high dollar stuff here. But I'm just really glad that you can come and talk to how you guys can have better sleep and benefit from having better sleep. So thank you so much for coming today.
Thank you. It's my pleasure to be here. And yes, it's easy. I live over behind Sam's. My house was built from when that was West Knoxville. There was no Farragut, hard to imagine. Well, there was a Farragut, but it was a little village out there. So anyway, yeah, it's great to be here. Really, I'm happy to do it because trying to help people sleep one person at a time is what it takes, really. So happy to do that. So I have about maybe 30 minutes of some slides and things. Some people need to slide out early, whatever. Nothing's going to bother me. But then I'm leaving the rest of it for questions, discussions, and whatever you all would like to hear about that would help you, friends, and family. So hopefully this will be very valuable for you. So National Sleep Foundation, and you can go to their website, they do polls every year. And this one was one of our most recent. I'm going to quote a few things. About a third of Americans are losing sleep over the U.S. economy and personal financial concerns, which we know things are still in some big trouble. And it's increased, 13% is low. Newer number is actually closer to 20% since 2001. And the number of Americans who sleep in less than 6 hours per night has jumped to about 1 in 5 people in this country, and 8 hours or less is really falling off to about a quarter of people. So it's really a big sleep loss situation, a huge national debt, as well as the national debt you hear about, and it's really discussed with one's doctor. So want to encourage that should happen. But seeking your help yourself, there's absolutely nothing wrong with that. You don't always have to go through your doc if it hasn't been an issue as you talk with them. So the most recent Sleep in America poll was about depression and sleep. And I'll give you a really impressive number. This was the landmark study about depression and sleep. If you have untreated sleep disorders, for it was 3.5 years in this study, your chance of developing reversible depression goes up 400%. Reversible anxiety to 300%. So you can see how there's this big connection with misdiagnosis and overtreatment of depression or bipolar or anxiety in our country, where it's actually underlying sleep disorders. So I'm going to mention more about that sort of thing as we go along. But there's this big relationship. 90% of adults who rate their sleep very, very good, they don't have depression symptoms. 65%, 7 in 10 Americans who are unhappy with their sleep, dissatisfied, are going to have some level of depression symptoms. So I'm using that term too because it's not necessarily real depression. They're tired, they're down, they're moody, they're things from lack of sleep or sleep disorders. And 2 nights a week if they have difficulty, higher levels of symptoms. So we need 7 to 9 hours sleep. Big rule of thumb is we are healthiest and safest on 8 hours sleep. And we are probably safe but less healthy on 7 hours sleep. And even 5 nights. You take a normal healthy 20-year-old and sleep deprive them down to 6 hours sleep for 5 nights. They have cardiac arrhythmias, their blood pressure it goes up, and metabolic disarray, all kinds of chemical changes in hormones, insulin levels, cortisol, on and on and on. So that's just 5 nights of 6 hours, and how many people do we know that do that all the time, a good part of their lives. So pretty cool stuff. So what does the sleep do for us? It is not downtime. It is big business, okay? okay? It's incredible value. So yeah, healthier, slimmer, younger, smarter, safer, and more beautiful, more handsome. So it slices years off our lives to get good sleep and enough sleep. So what happens, that it's really an active process while we sleep, okay? It doesn't just keep us more awake the next day. Our immune system happens at night. It's one of the biggest pieces of advice I gave during COVID. If you're getting your 8-hour sleep or sleep saturating, you have a much higher level of immune cells that are incredibly important in fighting COVID, when we clearly had no answers to treat it. Our nervous system regenerates and literally cleans itself. People who don't get 8 hours sleep, much higher risk of Alzheimer's and other dementias as we age. It literally cleans itself overnight, the brain. Fabulous, fabulous research. Memory is consolidated and stored. That's when it happens, whether it's knowledge or whether it's muscle memory, it happens in our sleep. Retaining from the day before and prepping for the next day. Heart and blood pressure are resetting. Hormones are produced at night in deep sleep and other stages, such as cortisol, insulin levels when we sleep, testosterone and growth hormone, which for men in particular, when we're done growing, keeps muscle on and fat off, and estrogen and progesterone. So the whole pituitary axis is very active. Appetite and metabolism are regulated, and the musculoskeletal system gets repaired. So just, quickly, and like little quizzing of yourself. Do you have trouble falling asleep? You wake up a lot, or you wake early and can't get back to sleep? Do you have any of these health problems? Heart disease, hypertension, obesity, GERD, reflux, headaches, thyroid disease, or diabetes? Massive link with sleep disorders. People that have those things, more than 50% of some of these will come back to it. Do you feel tired in the morning when you wake up and you did get enough sleep? Are you still tired, anxious, irritable, depressed during the day? Falling asleep when you're sitting still, doing inactive things. We know that activity can mask sleepiness, but we should be able to sit quietly, do quiet activities, work doing something monotonous, and not fall asleep during the day if we've gotten enough quality sleep at night. And sleep apnea is a biggie. So the last question has to do with, these are kind of easy indicators. If you snore, there's virtually 100% chance that you have obstructive sleep apnea. That's even occasional mild snoring. Normal people don't snore, okay? So, very, very serious condition with the sleep apnea. Restless legs, movement disorders. Jerking is restless legs when you relax or try to sleep. Again, getting sleepy during the daytime, dozing when you're in meetings. Traffic, really scary, but it gets that bad sometimes. Sleepwalking, acting out dreams, the overweight, yo-yoing kind of thing, very linked with sleep disorders. Memory loss, difficulty concentrating. One of the first things that the memory centers do when they're diagnosing dementias is send people over for complete sleep evaluation because of the massive link with focus, concentration, memory. This links back, I don't have another slide about it, but ADD, ADHD, we're number one, really the only country in the world that has much of that and diagnoses it and treats it. And we've known for years that at least a third of all cases of that are actually sleep disorders. And sleep testing is supposed to be part of the rule out for that, and yet it's almost never done. It's almost never done because the symptoms overlap so dramatically. You can flunk the test for that, but you don't really have that diagnosis. You just failed the testing on it. And sexual dysfunction, erectile dysfunction, and so on, fatigue, lack of libido, all can be sleep linked. So if you have yes to any of these, really be thinking about it. So let's learn more about the science of sleep. And people are usually very curious about this, all the fancy watches and techno you can get to try to tell you about your sleep. But if I may say, the most important thing is a lot of people buy some of these devices because they already know they're not sleeping right. So I come in and I listen to all, I'm sitting with patients and I'm listening to all they're sharing with me about how their sleep is unsatisfactory or things that are wrong with it and what's going on for them. And then they're like, would you like to see all the data from my watch? And I'm like, no, you've already told me what I need to know. Now I need real testing to know what's going on for you. So we can come back and talk more about that if that's of interest to people. We got two main factors driving our sleepiness. And one is homeostatic, which is really some of the chemistry in the body. when we've been awake for about 16 hours, the brain accumulates adenosine, accumulates other byproducts of the daytime and being up and moving and thinking, and actually puts us to sleep. It's adenosine. That's why coffee and tea and other things can keep us up at night, because caffeine is anti-adenosine, which is our natural sleep aid that puts us to sleep. So that builds up after about 16 hours, and we want to go back to sleep. So the longer we've been up, the greater that pressure to go back to sleep, no matter what we do about it. That is there anyway. Then our internal clock in the hypothalamus, light-dark cycles, and fascinating, but every single cell in the body sees light. I'm talking about every single cell. Some of the early research was done with the back of the knee. There's a clock in every cell in the body that detects light. So the darker your bedroom, and sleeping at night is, you could say, is the healthiest because of all of those factors. So there's over 70 million, 80 to 100 probably, Americans with a sleep disorder, and very few of these are getting treated. Just always think about, even if you think your sleep is normal, if you're having some of these other daytime effects, or other lab studies turn up abnormal, or some of these other health problems, even if you think you sleep all right, then you gotta be cautious about that. And thinking, do I really, or do I just feel like I do? Because that's certainly very possible. Sleep problems are serious, and more than half of all hypertension, diabetes, heart disease, and obesity in our country is caused by, linked with obstructive sleep apnea. More than half. It's huge. Huge correlation there. And then depression, anxiety, I've mentioned, also 7 out of 10 strokes linked with sleep disorders, especially sleep apnea. And it's got a high mortality. About 1,000 people die every night in our country from untreated sleep apnea in particular. So these are serious problems for our health, but also to our safety and public safety. So it impairs performance, affecting classrooms for children and adults, or any of us, when we're learning. The workplace, relationships, there's a 3 to 4 times higher divorce rate, or already high divorce rate. Now in people who have untreated sleep disorders. Driving, there's a several times higher vehicular accident rate in untreated sleep disorders patients. And that includes insomnia patients too. I mean, just because somebody can't sleep at night doesn't mean they're not going to be sleepy during the day, because if you haven't slept for 16, 18 hours, you're very sleepy, and the brain will fall asleep, will definitely fall asleep. But poor judgment, reasoning, reaction times, learning, these things have been studied carefully. Once we're up for 18 hours, our reaction times and cognition is the same as someone legally intoxicated. 18 hours sleep. Yeah, who knew? But it's very serious. And then workplace productivity is a big factor. So it's really closer to 2 hours now, less than our ancestors did 100 years ago. We sleep that much less now, and there's obvious factors that you all know about what gives you less sleep besides family obligations and other things. And it's, I think, getting better. I hope it's getting better, but the misperception that sleep is negotiable. It's kind of wasted time, it's downtime. I got, 2 jobs I'm trying to do, the kids keep me up, there's, all kinds of things. This is my personal time to stay up later after, everybody else is in bed or something. There's so many reasons people do it. It may be temporarily satisfying, but it certainly won't pay off for them in the long run, with the price they're going to pay for their health. So it's simply not prioritizing it a lot for many people too. Adults do need an average of 8 hours of sleep, and that's not just time in bed. 7 hours in bed, you say, well, I'm trying to get my 7 hours minimum. You're not sleeping 7 hours. Nobody sleeps solid for the time they're in bed either. So 8 hours for adults, 9 hours teenagers need, from about age 14 to 18 to 20, sometime in that area, to be fully rested. And younger kids, of course, 10, 12 hours, that can vary a lot, in the early ages, what an individual child needs. Now, the quality, the stages of sleep, a lot of people are always very curious about this. So, one is what we think of as drowsiness. When we become drowsy, you pull off the road, and take a little nap or get up and walk around, you just fell asleep driving. Let's be very clear on that. There was nothing in between wake and sleep. Drowsy is driving. You know, driving drowsy, drowsy is asleep driving. So that's stage 1, and this is the percentage of a particular night. And 2 is light sleep, where we're easily awakened. Somebody can wake us up pretty easily if there's a noise or something in the house. We wake up easily. And 3, sleep. So N stands for non-dreaming, non-REM. Okay? And 3 is the deep sleep. And these are numbers of adults. Kiddies get maybe, first graders, maybe up to half of their night. Preschoolers is the deep sleep, which is why sometimes they're scary, deep asleep, and you can't wake them up. You know, you can tote them out someplace, and they're just a little sack of taters, because they go into really deep, deep sleep, even a lot of it early on. Now, REM sleep is extremely light sleep. It's very, very light sleep. It is not deep sleep. And, you know, what is the difference of deep sleep? Probably is restorative for the body. It's when a lot of the hormones are produced in the pituitary axis. So very restorative for the body physically. REM sleep is, I call it our sorting and filing processing. REM sleep is when we consolidate memory. It's when we get rid of some bad memories and try to stick with the good ones. REM sleep is largely why 5 witnesses can say they saw 5 different things. They saw the same thing probably, but they remember 5 different things as it's processed. So very fascinating in that. So all the stages are important in the right proportions. Some people in their sleep test focus a lot on, did I get enough of this, enough of that? Well, it's really the right proportions. There's no one that's the most important. Even the light sleep, that's okay. We get into that as we transition in and out of the other stages a little bit. The other quality factor, though, yes, you want the different stages. You want it not to be fragmented. That's what can happen with a poor sleep environment, sleep disorders, because fragmentation wakings during the night. So you can have all the right stages, but fragmentation, then your sleep is still ruined. Okay, so it's all of that. And the watches have no way to tell what stage of sleep we're in. I just got to tell. Okay. Yes, they're probably pretty well validated. Chris can speak to this better than I, but pretty well validated for heart rate and heart rhythm, and some of them even for oxygen level. But once we get into them telling you if it was restful sleep, non-restful sleep, whether you were in deep sleep or not, they're really bad at it. Okay, it doesn't do it. We have wires hooked all over, and we're looking at, for REM sleep, we have to look at muscle activity, and there's changes in heart rate and brain activity, and we're trying to record waves through here. That's what we tell what stage of sleep is brain waves. It doesn't happen down here on our wrist. There's just not those kind of changes. So I guess stay focused on what those kind of tools can do for you, and use them and enjoy them for that. So, and timing too. So quantity, quality, timing is sleeping at night. So you've already heard about the quantity, and then this is just another little representation of the percentages of the different stages. Okay, so what drives sleepiness? Well, the longer we've been, now already, the longer we've been awake, the sleepier we're going to be. So that's the homeostatic factor, the chemistry that builds up the pressure to sleep, and then our internal clock. So I just really wanted to touch here on larks and owls. Larks don't get up at 2 or 3 in the morning. They may get up at 5 or 6, but they're high functioning early in the day. That's a lark. I'm a lark. Chris is a lark. You're a lark too. Yeah. We're high functioning early in the day. Okay. And owls, they don't stay up till 1, 2, 3 in the morning. That's not an owl. That's learned behavior. Owls are high functioning at night, but they're still going to go to bed later. We might be in bed at 9 or 10. But owls maybe are going to be high functioning till 10, 11, 12. But it doesn't mean that they're going to be up half the night. That is not an owl. Okay, that's actually delayed sleep phase. It's actually linked with a shorter lifespan. larks and, at least a reasonable earlier schedule is linked with longevity and health. So sleep delay in teens. Teens naturally want to go to sleep a little bit later. It's why high school should start later than the little ones do. Seniors, there's a condition called advanced sleep phase where they want to go to bed earlier and get up earlier. And there's some variability in sleep requirements, but it still is a very narrow bell curve in that 7 to 9 hour range. So just to touch on a few sleep disorders, because a lot of people like to learn just a little bit about this to start to troubleshoot. There are over 100, and now they're all broken down into hundreds of different codes that can be used for them. But sleep disorders, treating it is not about my just treating sleep apnea. There are sleep centers and docs that only do that, but I rarely find somebody who only has one problem related to it, to really getting them better. So there's a whole spectrum of the hypersomnias. Narcolepsy is the famous one, but we'll talk about in general. Insomnia, the cycle disorders, parasomnias, and then sleep disordered breathing, the sleep apnea. So just going to pull out a few. Starting with the hypersomnia. This is a spectrum of conditions. The one I mentioned will often get misdiagnosed. The hypersomnia is misdiagnosed as laziness, boredom, ADD, ADHD, dementias, depression, and so it's really often not thought about enough, but even more than 50% of sleep apnea patients have one of the hypersomnias. So of course the most common cause in our society is just not sleeping enough, and so people are sleepy during the day, so it's one of the things we do rule out. So, of course, it includes obstructive sleep apnea. Up to half of people with obstructive sleep apnea have some permanent sleepiness. They're literally damaged cells in the brain from years of not treating it. Narcolepsy, though rare, is the famous one, and then the general hypersomnias. And we actually diagnose these with testing. Everything sleepy is a narcolepsy. Narcolepsy is quite rare, as you're going to see. Should I leave? Let's see. Yeah, I think I've got some other narcolepsy slides in here. But anyway, obstructive sleep apnea. So it's really fairly common, up to a third of adult males. So it's not everybody, but it's a lot of people, and about half as many adult females between the age of 18 and 65. It is genetic, period, like so many health problems. In age, it gets worse. Middle age, if people have been a smoker, it makes it worse. It causes weight gain, but once you're overweight, it makes the apnea worse. Menopause, whether it's surgical, natural, or chemical, brings out the obstructive sleep apnea. Okay, so these are risk factors that stack up over the years for people. And then thyroid disease, even when it's treated, worsens sleep apnea. So there's a number of other risks, but these are some of the top ones. So remember, women, children, and thin people, I say, get missed for this all the time. You don't have to be a big fat old man to have obstructive sleep apnea. We've known better than that for 30 years. Some of the early research was done on the easy ones to identify, of course, but we've moved way past that. In fact, I try to reassure new patients that I see, the street runs the other way. Obstructive sleep apnea causes obesity and diabetes in a number of ways. So I really, I don't fat shame people in my clinic. It's like, we're going to treat you. It's so exciting. And then you're going to be able to lose weight. You got to do the right things, but then you're going to be able to lose the weight. So if apneas have been seen, like stopping breathing, you definitely have apnea. So just to help you understand a little bit, what causes apnea. So this is a narrow airway. This is looking at the side, laying on the side and the back, and looking from the side. So this is the nasal passage, and of course the mouth, big old tongue in here. And this is a narrower throat, a narrower passageway for airway here, which is typical in obstructive sleep apnea families. This is why thin people can have it, and I've tested people who weigh 600 pounds that don't have sleep apnea, okay? And so what happens in sleep is this whole area tends to collapse. So 3 levels, the back of the throat, behind the tongue and jaw, and then slightly further down, this area collapses. So all the treatments are aimed at adding support in here to keep this more open. Notice I did not mention the nose. Sleep apnea doesn't happen from allergies, sinus congestion, deviated nasal septums, other things. Treating those may help a little bit, but it really happens down here in the common pathway, whether the person is nose or mouth breathing. So, consequences. Well, these are health problems we've been mentioning: the hypertension, diabetes, obesity, PCOS. So the low hormones in women too, and the obesity with the PCOS is really significant. And miscarriages and infertility. This gets overlooked a lot for the young ladies, but it's a big, big factor in all of these things. So heart disease, especially congestive heart failure, coronary artery disease, and up to 80% of heart arrhythmias are linked to sleep apnea. And then they do have higher incidence of accidents, divorces, mispromotions, school failure, misdiagnoses with other things. So we've talked about why people have it: family history, age, gender, other things make it worse. So let's talk a little bit more about treatments. So surgeries, we do a lot fewer of these now because they just don't have a high success rate and they hurt a lot. Okay, so don't want to do something that could even make it worse. But all kinds of things have been done where the lower jaw gets moved forward. Sometimes that will help, but it doesn't really help the collapsing. You can literally make the tongue smaller, take out pieces of the tongue. They are rarely a cure. In children, if they've got massive tonsils, that may help for a while. But I should caution that children, if you're doing tonsillectomy for apnea or snoring, there should be testing done before and after. They're higher risk for tonsillectomy than kids getting them out just for infection. It's very important for the little ones too. Oral appliances, we do a lot with these, and everybody's selling them. You can make your own from kits on the internet or the local drugstore, and they don't work. I'm going to cut to the chase. It's guesswork. I did that for 20 years plus, and now for the last 8 or 10 years, we do still use oral appliances, but it's refined. We do a pre-test to know if they'll work, and there's an exact setting where they need to be. So I just tell you that to caution you not to just run out and get one of these where it's just set for guesswork. They just don't work that well. They can actually damage the jaws and the teeth, the boil and bites, and some of the simple ones. You hear about CPAP, and there's various kinds of PAP: CPAP, BiPAP, VPAP, and they're fancy little air compressors. They're tiny. I will tell you, the masks now that people use are tiny little nose pillows, little things over the end. Anybody that's got a big mask, well, they probably shouldn't. A few people like them, but that's usually inexperienced prescribers. So they're pretty easy to use the way they are now. They're very, very quiet. And there's nothing better than CPAP if the apnea is very bad. Bongo, it's just a little thing in the nose that's got a valve in it, opens and closes. And then you may be seeing the ads on TV for Inspire, and it's actually a stimulator, kind of like a pacemaker for the upper airway that you turn on at night that makes the muscles stiffer in here to stay open. So you can see we're trying to keep this open in here. And this is, again, very, very significant. It kills so many people needlessly in our country. It's a tragedy. And it's young and old. It's an equal opportunity killer. I had a 25-year-old skip her CPAP one night not long ago, and she took a long nap, sadly. She did not wake up in the morning. It happens to people. It really, really does. So treating is important. And know that weight loss improves apnea, but it does not cure sleep apnea. Okay? It opens treatment options. The worse the apnea gets, you got to go for one of the positive airway pressure treatments. Sometimes Inspire will work, the actual surgery. Some of the other things are better for milder apnea. So the earlier people get treated, the more likely all the options will help them. Back to the narcolepsy, hypersomnia situation again. So this is rare. It's only about 1 in 1,000 people. So narcolepsy is really, very rare. You hear that term a lot. Most people that say they have narcolepsy don't, and it does not really run in families. Even if you take identical twins, only one has narcolepsy. Okay? So, more details on that, but not to go there. So, it's pretty rare. Sleepiness, something called cataplexy, which is momentary weakness in the daytime that's actually part of REM sleep. Muscles are very weak when we're dreaming. That's why it feels very relaxing sometimes. Sleep hallucinations, awake and dreaming at the same time. Sleep paralysis, stuck in that weakness of dreaming and you're partly awake. So narcolepsy is a very specific condition where sleep and wake and dreaming all start to intermingle. So it's a very specific condition. And they also sleep poorly at night. That's what's little known about narcolepsy. These people are not only sleeping during the day and the other hypersomnias, but actually don't sleep well at night. So micro sleeps during the day and micro arousals, wakings at night. So we've got various medications, not to go deeply into, but these are treatable and we no longer have to use some of the old stimulants. And then the hypersomnia is part of this spectrum, very, very similar without all the dreaming symptoms that I was mentioning. So insomnia, to remember, it's usually a symptom, not a disease. So if it's something short term or situational or something like that, sure, you just want to treat it symptomatically, temporarily, but in general, you want to think in terms of underlying medical psych types of conditions that are actually causing it, the other sleep disorders as well. And then parasomnias we treat too, so we treat all of this, but everybody knows about sleepwalking, sleep talking, sleep eating. And usually it's relatively harmless and they get disruptive. There's a rare one that's called REM sleep behavior disorder where people literally do act out their dreams. They're pretty easy to wake up because we're in that super light stage of sleep dreaming, but acting out the dreams is different than sleepwalking. They're very difficult to wake up because they're in that deep sleep. It's kind of a good indicator there. The dream acting out is always an early sign of Parkinson's disease. So, if you really feel like you need evaluation, go to an accredited sleep center, an accredited program with an experienced fellowship trained boarded doc, and we focus on the whole sleep history, an exam, and get all the information we need. So there's various other tools we use after that to really analyze this, including monitored sleep tests that are more like ICU, where we're getting all of this information and it's very, very accurate. So we really want to reduce the diseases, the death that come from this, especially cardiovascular consequences and other health problems that come from it. Reduce the sleepiness, which has terrible liability for people in many ways, as you know, and just improve their quality of life. So treating sleep disorders, as I said, it changes their life, but it definitely saves it too. So what should you be doing for good sleep health? You know a lot of this already, but number one is regular bedtime and waking schedule. In our 24 hours, we kind of know this now, but it starts with what time we get up. Because what time we can go to sleep starts from what time we get out of bed. Remember, the adenosine and the chemicals are building up that put us back to sleep and give us healthy sleep. So especially getting up about the same time as much as possible. If it doesn't bother you, you can vary it more, but for people that want to make sure regular bedtime, regular waking schedule without varying it too much is optimum. Stimulants, stimulating behavior close to bedtime, that's the caffeines too, the simple things that are out there. That relaxing bedtime routine for the last hour that stays away from the electronics, even the blue light filters don't filter enough. The blue light is what's in the sun, and the electronics are stimulating, but also the blue light is like you just went out and looked in the sun for a little while and then you hope to go to sleep. It just doesn't work very well. And kids too, especially, for every piece of electronics in the bedroom, a teenager loses 1 hour sleep a night. That's the statistics. So check them in if at all possible, and think about that, because they're really paying the price for it. So the conducive, cold, dark sleep environment, whatever is good for you, but usually cool and very dark. Limit daytime napping for healthy people, and the late alcohol and caffeine, bad. Exercising. Chris is going to stay on you about this. Regular exercising, it really does make a difference. I mean, Americans, the way our lives are structured, we don't do the walking and the regular exercise just in life, that other countries do. So we need to actually make an effort to get the exercise we need, and it's really great for our sleep. And then no clock watching, because that has never helped anybody sleep. as soon as you check the clock to see what time it is when you wake up, you're at a higher level of alertness and awareness, so it takes further and longer to go back down to get back to sleep again. So everything I'm quoting, data driven. So shift workers are pretty interesting. It's a sleep disorder. Does cell cells have night people? Night staff, or is everybody on days? Yeah, pretty much days, yeah. So, but we do have treatment for it. You know, if you may have friends or family that are involved with this, and we have all kinds of strategies to help them with the shift changes, to try to sleep and get as much sleep in the daytime. So suffice it to say that we actually at Sleep Center do treat shift work disorder. So I'm going to spend a lot of time on that. Alertness at work, you know, short breaks. I mean, they do getting up and walking around and getting, you know, something, a cold beverage, something, you know, may help for alertness and working with the body to watch for drowsiness. Hopefully, I suppose y'all aren't doing anything terribly dangerous here, but this gets even more important on potentially safety-sensitive type situations, and I think things where, you know, but nobody wants to be making mistakes on the job. That's never good for our evaluations and our work. So watching for that. Walks or exercise on breaks. You know, companies that allow some of this, it's great. Don't skip meals. You know, that's bad for causes obesity. Skinny people eat regular meals. So Chris knows all about this for sure. But this is important for alertness, because when we're bonking and need to eat, you know, you're going to be sleepier. And do boring things early when we're more alert and fresh. And night workers, some use of caffeine may be helpful. Hydration always too. So in employers, I guess we've got some managers in here. I asked before we started, you know, but yeah, the need for sleep, the danger of fatigue. So thank you for being here too. Most workplaces now have pretty bright lights in work areas, and you know, sufficient breaks and days off, avoiding too much overtime. So hopefully that's not too much of a problem here. There are some workplaces that don't allow napping, you know, during breaks or during lunch breaks, but it's rather foolish because, you know, during the day, there's solid research to show that after we have a power nap for 15 minutes even, we're more alert and productive for 3 to 4 hours afterward. So I always encourage employers to think in terms of that's the employee's time. The state requires it, it's good for them, and they're going to be, you know, a better worker, you know, when they come back, if they've taken their little power nap, if that helps them. Okay, so anyway, just in summary, you know, sleep is essential now, you know. What did you say?
We're not getting sleep pods.
I wasn't going to suggest anything specific.
Go out
no, oh my goodness. Yeah, I know. There's some things going on in Silicon Valley and things that are just, I know, a lot of hand holding too. Get more sleep at night. Yeah, okay. I'm talking about head down. I'm talking about head down on the desk kind of nap. So yeah. Oh my gosh. So of course, yeah. Anyway, we could do it. We could have a lot of fun with that. Anyway, so think about the sleep disorders as fairly common. They're serious for your lifestyle. They're serious for your health and safety. And there's help for everything. So I'd be happy to have any discussion now. Have some of my cards here, and if you need to reach out to me personally too, our website is barkersleep.com. And I've got some cards here, and got the phone number and things on it too. So if we can help anybody personally, we'd be happy to do that as well. So what would you like to talk about?
I think sleep pods.
She's already said no to that. You put it on your Christmas list, wish list, but
I was just gonna say you could add it on the
What do you think about magnesium?
what do I think about it? It got anything more, you know, specific? It's not a sleep.
Taking it to help sleep. That's what it's not.
No evidence of that. There's no evidence that it's a treatment for restless legs. Patients are often told by other physicians or read online, Dr. Google, and that magnesium's going to help with all that. You know, magnesium's fine, but we don't have any evidence that, you know, additional doses of it outside what you would get in a healthy, well-rounded diet is going to be, you know, benefit sleep. A lot of people ask about melatonin. You made me think about some of the other over-the-counter type things. Melatonin is only useful to improve sleep maintenance. If somebody's waking up too often and can't get back to sleep, be careful with it. It's okay to try a little bit of self-medication, but a lot of the sleep disorders cause waking and not being able to get back to sleep too. But there's nothing wrong with trying some melatonin. Just remember the dose of melatonin at bedtime. No gummies, no extended release. I don't know why adults need gummies anyway, so I'm going to make fun of that. Low dose. In fact, many of the preps you can buy over the counter have 10 to 20 or 30 times the amount of melatonin is it that the label says. So that's another reason to be very, very careful with the melatonin. But 0.5 milligrams to 3 milligrams is the dose we use as sleep docs at bedtime to improve sleep maintenance the second half of the night. Why does that work? Well, in the super dark, our brain produces melatonin the first half of the night. Now adenosine helps us get to sleep. Well, the first half of the night, the brain produces melatonin to keep us asleep. So all we're doing is with a small dose is tweaking that natural mechanism. Once you get above 3 to 5 milligrams, it's in your system 24/7. That's not what you're trying to do. And the preps, even with a good brand, you can name some of the good top brands, they still have a highly variable amount of melatonin in them. So it's always better and it's usually higher. Some of them even have a little THC, a little bit of CBD, all kinds of other stuff in there that's not on the label too. When they analyze them, Harvard's done a lot of this research and other things. So not against using it, it's just right now the FDA doesn't regulate a lot of the over-the-counter things the way we kind of expect they might do, but not doing that. So. Yes.
Is sleep like nightmares or sleep anxiety treatable? Because a lot of my dreams at night are like nightmares or anxiety, and I wake up and I'm exhausted because I feel like every night I've just been so busy fighting off stuff.
There actually are some of the sleep disorders that will cause that. Some of the sleep disorders we treat actually are worse in REM, so it brings that out. And so do you feel like you wake up a lot when you're dreaming?
Yeah.
And that's a sign then too, because we don't necessarily wake up because we're having nightmares. In fact, a lot of our dreaming is getting rid of the bad stuff. PTSD is caused by people not getting enough sleep after a trauma because of the sorting and filing mechanism, that I was mentioning. So, a lot of it's bad or crazy stuff or whatever too. But we can treat it. And it's just trying to understand what the underlying problem is. I look at meds people might be on that would cause that or worsen it. But people don't normally remember our dreams. We dream, about a quarter of the night, right? We don't remember all that. It really is kind of real time, like we're watching a movie, is what we understand about it. But yeah, we shouldn't wake up a lot during it. So when one of my patients says to me, "Doc, it's great, I can remember my dreams now," Dr. Barker starts worrying. Okay, because I know they're waking up more. It's not.
I remember all my dreams.
Yeah.
And I'll try to wake up and I'll try to not dream about the same thing. I'm like, all right, dream about puppies or cookies or something nice. And then I'll fall asleep and I'll have the same dreams going on.
Same, yeah. Sorting and filing, but normally we normally don't remember a lot of our dreams. So maybe a little bit toward morning. Do you dream during naps? Okay, good, because we're not supposed to.
Yeah.
We usually don't dream until we've been asleep about 2 hours. So.
What does it mean if you do dream during that?
The narcolepsy that I mentioned, narcoleptics dream a lot. So they have too much dreaming. They dream a lot. They start dreaming very quickly. In other words, they have dream sleep, REM sleep, when they should be in other stages, which is also not good. So a lot of times they will have dreaming during naps, or that they start dreaming right after they go to sleep, or things that normal people don't do. And narcolepsy is quite rare, but
So I did a sleep study and they could not confirm nor deny narcolepsy. So what exactly does that mean? He said, I can't say that you don't have it, but you might have it.
I can't say, because it's not like, you do the test and you have it or you don't. So there's something flawed about that discussion. Yeah, so, yeah, you know, when you do the tests and you understand what you're doing, you know, it's not a maybe, you're pregnant or you're not.
Gotcha, yeah, he
yeah.
described it just as idiopathic hypersomnia.
Okay.
Yeah.
And that's part of that spectrum, and so it's totally treatable, yeah, so it's totally treatable. So I'm not sure why they would frame it up, yeah, you know, the narcolepsy, it shows up on the MSLT, the daytime test, and it's very distinctive. So, now, if somebody has the clear signs and symptoms and yet the daytime test, the MSLT isn't, you know, doesn't display it, we kind of go with the clinical part too. So you got to put all that together. There's a genetic test for narcolepsy too, but 20% of normals are positive for the same genetic test. So it has to all be used together, and we don't necessarily do the blood test right now for it because it doesn't change the treatments we can use at this point in time.
So can you be narcoleptic without like the cataplexy and like the hallucinations?
Yes, but it'll show up on the MSLT. Different people develop part of the symptoms of narcolepsy at different phases of having the disease. There's narcolepsy type 1 and narcolepsy type 2. Narcolepsy 1 has the cataplexy, but 1 and 2 both have the other sleep hallucinations, the sleep paralysis, some of that. So, but it can develop at different times. The peak onset of narcolepsy is sometimes somewhere between the childhood, the teens, and 30-something. But yeah, you make a solid diagnosis. It sounds like they were going with the idiopathic hypersomnia, but it's not that confusing one way or the other generally.
Yeah, I left them pretty confused from the sleep study, so.
Are you better?
No.
I see. Well,
he gave me a stimulant, which that says don't take enough stimulants for sleep.
we don't. We have better things, is the way I would frame it up. Stimulants actually don't really work in the wake-promoting areas of the brain. Largely the sleep-wake pathways of the brain have been mapped out, and so we have more specific medications. The brand names. There's modafinil is Provigil. There's Nuvigil, Armodafinil. Sunosi, which is a solriamfetol, that's a newer one. These are daytime wake promoting, and another one called Wakix, which is pitolisant. These are work strictly in the wake promoting pathways of the brain, and they don't have mood effect, heart blood pressure effect. So that's what you want to use. We almost never use the stimulants anymore unless insurance won't pay for anything good. Which we face all the time now, unfortunately. And then there's nighttime medication too, because hypersomnia patients, that whole spectrum of conditions, have more wakings at night, micro wakings, and then even micro sleeps during the day. So it's got to be like thoroughly treated to get everything properly treated. Yeah, so you don't feel like you're doing great, well, be happy to help if you want. Thank you.
Can you do I have to do a new sleep study or do they?
It just depends. I'd have to see details. How long ago was it?
About a year ago.
Yeah. It depends on what I see about it, the quality of what was done. Usually, for insurance purposes, for me to take over, I got to repeat some things, but it varies. Yeah. Most important thing is getting really good treatment. Anybody have? Oh, you had a question back there.
Are there any natural substances or remedies that help you go to sleep?
Well, we talked about the melatonin a little bit. And, one of the biggest things is that regular sleep schedule that you're talking about. So we've really talked about some good habits and things that can produce it. But no, I'm all about doing things as naturally as we can. So, scheduling and control of sleep environment and that kind of thing is probably some of the top of the list. We're a big substance using, country too. So I don't have some natural supplement or anything that's ever been identified that I could tell you to do more of that is going to be, because we don't know of anything else. You want to avoid the late caffeine because that's anti-adenosine, which puts us to sleep, and then maybe the little bit of melatonin, but those are really the only things that we know of truly, over the counter or supplement type thing or anything like that, that could benefit you.
So do you
I tend to take Benadryl a lot to help me get to sleep. Sounds like that's not a really good solution.
It's not a really good solution.
Okay.
It's not. Here's why. Specifically, here's why. And any of the sleep aids that contain the allergy type medicine have been taken off the market in most countries. Not here. You know, all the NyQuils and the Tylenol PMs and all of that are just big doses of allergy type medication. The problem is the sleepiness is a side effect, and the side effect starts to wear off the longer people take it. And so then they have to go to a higher dose, same cycle, higher dose. It's very habit forming. It gives abnormal sleep, and a lot of those are in the system perceptibly for up to 12 hours. So using that kind of substance for sleep is a contributor to morning accidents too. We're the sleepiest in 24 hours. One of the sleepiest parts, maybe not at bedtime, but the next sleepiest time in our 24 hours is when we get up in the morning, the first 2 hours. A lot of early road crashes, people that hop out of bed and jump in their car, you know, like barely throw their clothes on and leave the house kind of thing. They're still pretty sleepy. So, but yeah, that's the main problem with it is the habit-forming nature of it, the abnormal sleep. Yeah. Now, people take some Benadryl sometimes because they have allergies, bother their sleep. That's another story. So, I'm not just against Benadryl completely.
So would that be the case, like, my antidepressant, a side effect is sleep to help with my insomnia. It's drowsiness, so it makes me go to sleep to help with my insomnia. Is that the same, like?
That'll usually wear off too, you know, the side effect of it. A lot of the antidepressants are given to help with sleep, and they will, but again, that side effect almost always wears off. Trazodone is one that's used a lot. Yeah, and there's actually, you know, so not to be critical of, you know, if it's working, okay.
Well, we're trying to get off of it, so.
Yeah, there's actually research papers that show it doesn't help sleep long term. There is 0 research papers ever to show that it is helpful to help people sleep. So I don't ever prescribe it. There is, you know, and again, the question always is, why can't we sleep? You know, why can't we sleep? You know, so, you know, everybody reaches for certain things, you know, the depression or the this or the that, you can't sleep. But, you know, what if, you know, there's other underlying sleep disorders, so when it's, you know, chronically treated. But yeah, the use of trazodone for sleep, I don't ever prescribe it because the only data that's out there shows it doesn't help. And yeah, I have been a doctor for 42 years, so I remember when trazodone, Deserel, was actually brand new. And we used it all the time because it was one of the first antidepressants that came along, and we told everybody, we'd start on 50, 100, 150 anyway. I remember all this. And we told people, don't worry if it makes you sleepy, that'll wear off in 3 or 4 weeks. So I have kind of a different historical perspective about using some of those kinds of things because we know very well it's only like a short-term fix. But again, you know, not to be overly critical, if it's helping somebody, but you know, then if it's not helping,
Recently added me on Pros something. It's a PTSD medication for sleep.
prazosin. Yeah.
That's what they recently added me on.
Yeah, and so all well and good, and that is very commonly used for PTSD. But again, everybody, you know, always think about, we're big on treating without not always understanding the underlying condition. And I'm not the brightest candle on the cake necessarily, but I think one of the most important things in practicing medicine is, why does somebody have it? Why does somebody have low T? You know, why does somebody have high blood pressure? Oh, it runs in the family. Well, what if sleep apnea runs in your whole family? You know, so we write too many things off. I think that sometimes we need to look for underlying causes is the only thing I would add to that is, you know, how can we, there's no test to say for sure that depression is giving you insomnia. Yeah. So a lot of things are a rule out diagnosis in healthcare too.
What did you say if you snore, your chances of sleep apnea, like you automatically use it?
It's almost 100%. It's very, very, very high. And a quarter of cases don't snore at all. So we worry a lot about sleep apnea because it really is a killer condition. It's, you know, breathing's closing off in here, so it's very, very serious.
So you would recommend anybody who's a snorer to probably use it?
get checked. And you know, again, you honestly need to be checked. A lot of mild sleep apnea gets missed in a lot of places. And it's not just an East Tennessee thing in some of the centers, but even mild sleep apnea is when you're a candidate for a lot of various treatments for it. But yeah, snoring is a very pertinent sign, very, very clear indicator to really be thinking obstructive sleep apnea. There are some schools of thought that there is such a thing as benign sleep apnea, and it usually means it's, when people say it's benign snoring, it's usually missed sleep apnea. Got missed on the test all too often.
What's that bongo device?
Yeah, the bongo, and you can look these things up online.
I did.
You looked it up, yeah. And so it's just a little intranasal. It is prescription, yeah, and it is for milder sleep apnea. It's on, you know, the more treatments that, you know, the earlier people come in, the more treatments. But it's just a little intranasal. And the inventor of it, he's a wonderful geeky old guy, and met him. We were doing some presentations side by side at our San Antonio meeting a few years ago. But he named it bongo because if you turned it up, the part that sticks out, it looks like a set of bongos. I think he should have named it something respiratory related, breathing related, but be that as it may, he was very proud of naming it a bongo. And so, yeah, so all well and good. But
it's prescribed based on what level of sleep apnea you have.
well, it works better. It works better for thinner people and milder sleep apnea. The worse the sleep apnea, we see the efficacy rate for the bongo go down, but it doesn't rule it out. What happens, people try it. We prescribe it, they get them, we fit them, they come in sizes. It has to really seal and fit really well. And then you try it. Most people know inside of a week if they like it. And then we test with it in. So, you know, normally we might do a CPAP test to find out what pressure level that is needed to support the airway. But with the bongo, then number one is, do you like it? Number two is, there's no settings on it. Either it works or it doesn't work. Yeah, but they're pretty convenient for people.
It's cordless.
Oh, there's no electric involved. It's just that little device. So I have some people that use it part-time for camping or travel, or some people that use it, you know, every night as their only obstructive sleep apnea treatment. Yeah.
I walked in a couple minutes late. Did you discuss the sleep positions and which ones are more preferred over others?
I did not, because there really aren't any other than stomach sleeping is bad for our heart, all of our internal organs, and our back. Sleeping on the stomach often will make obstructive sleep apnea worse because people have to get the airway closed off more. With stomach sleeping, it puts the spine in a abnormal curvature for many people. So, but as far as say staying off the back for obstructive sleep apnea or things like that, you sometimes hear about. Not everybody's apnea is worse on their back. More people, the sleep apnea is worse when they're dreaming in REM sleep because we're so relaxed all over. And this closes off more. So did you have a more specific question about what's the best sleep position?
I was just curious because I either sleep on my back or my side. I don't technically snore or anything, but I'm always curious because my husband does. So sometimes I'm always like, get off your back because you'll stop snoring.
Yeah, it doesn't mean the apnea is fixed. So sometimes the quieter the person, the patient, the quieter the less they're breathing. So yeah, we have plenty of people that are quieter on their side and their apnea is worse.
So you're killing it, basically.
So yeah, there's not and there's a few patients that back avoidance is helpful for this sleep apnea, but more often, even on their side, the apnea is worse in REM sleep, and then just stomach sleep is to be avoided. Even though some people, sleep on their stomach to treat their apnea, it doesn't make it better. It can be worse in the supine position. In the prone position. So. Yeah, the sooner he gets in for help, the more options he might have, and then you'd sleep better. Then you would sleep better too.
Yes.
Yes.
I have a quick question. So I do have narcolepsy. I did a multiple sleep test when I was 18. But I never experienced I've never experienced a cataplexy that I remember. Right, it could have been when I was much younger or something. But restless legs and then some paralysis, unable to move when you're relaxed or whatever, I've only experienced when I was pregnant. Does that make any sense to you?
No. I mean, you know, first of all, sometimes people have part of the symptoms when they're younger, but they don't usually go away. Now, restless legs usually it often will. If people that have it, it'll get worse during pregnancy because it is related to iron. So restless legs is iron linked. A storage form of iron in the body called ferritin works in the brain preventing restless legs. So restless legs sometimes get worse because the baby's getting everything when we're pregnant.
Like I'm always a bouncer, but I'm like, I don't know if that was something I started.
That's not
as like a response to try to keep myself awake, or if it's an anxiety thing, or
yeah, that's not restless legs.
Yeah,
that's
well,
a
that's-
habit. Yeah.
So I mean, and I know you can have restless legs also without having narcolepsy. So that was, I guess,
True
that
that.
was probably more my question. Is just like, when I experienced restless legs when pregnant, was that a byproduct of pregnant or a byproduct?
Yeah,
of
that's a separate. It may come back later too. And if people have restless legs at any point, 80% of the time they'll have a movement disorder in their sleep called periodic leg or leg movements, periodic limb or leg movements. So there's all of that. But yeah, cataplexy. Back to kind of that part of your question. Cataplexy can be very, very. There's two types of narcolepsy. Only type 1 has that. And it can be very, very subtle. I have a lot of patients when they first come in, they do have cataplexy, but they didn't really think about it because it's a partial cataplexy. So the most severe cases of cataplexy, the person literally has to sit down. And there's no passing out with this. This is strictly muscle weakness for a few moments. And they literally have to sit down because they're all rubbery. But some people, it's partial, where they may just drop things. They may just trip slightly. They may get slurred speech for a moment. Eyelids get heavy or a little bit droopy. And a lot of times people don't really think about it because it's so momentary. It's most common with laughter. And they'll think I was just laughing so hard I got weak. I have a cook in the kitchen that when she's one of the school kitchens, when they're cutting up and laughing really hard, she for years, couldn't hold a knife or a spoon or something for a few moments cooking, and she thought she's laughing so hard. And I have a hairstylist I can think of who, when she'd laugh real hard with a client, she would drop a tool and thought she was just being clumsy. So some of them, one guy who's just when he's super angry, it started happening first when he was disciplining his 3 toddlers, 3 boys that were like 3, 4, and 5 in a row.
Oh,
And he'd get, I know, exactly. So when he'd get super frustrated, then his speech would slur, which they thought was hilarious, which did not help a thing. And so it can be subtle in people. He just thought he was so angry. And I'm like, no, that's your cataplexy. And so we started sorting it out. So sometimes people don't know they're having it because it's the partial type. So, or you could have narcolepsy type 2, which doesn't really have that. I do think.
I can't remember which. I'm 41 now, so that was a long time ago when I did my sleep study.
And you haven't had it repeated since to determine more about it?
I did one other time when I was like 25, and it was the same.
Yeah. So.
But I don't remember.
There aren't some newer treatments coming along, but yeah, and that's part of it. It goes back to part of does somebody have narcolepsy or not? It's putting together. Thank you.
Thank
It's
you.
pretty-
You're fantastic.
Oh, you're so sweet. Thank you. It's putting together the clinical history that the patient tells you and digging a little bit, not leading the witness, digging because we know what to look for, and then putting that together with the testing and things. That's how you make the diagnosis. And then there is the blood work, but we rarely do that because, again, that's really looking for type 1 narcolepsy, and we do not have that specific treatment for type 1, the cataplexy, that we may have later. So, yeah. But yeah, narcoleptics, whether it's type 1 or 2, they more commonly have all the other sleep disorders too. You gotta be careful and keep getting retested periodically, whatever that might be, every 5 years or so. Not always the daytime test again of the MSLT, but looking for, because they often also have sleep apnea and movement disorders and parasomnias, and those need treatment along the way too. And then the nighttime treatment for narcolepsy can be really important because narcoleptics don't sleep. But anyway, thank you. You've been a super audience.
Thank you.
My notes are super.